We present a case of hepatopulmonary syndrome in a young adult who presented with orthorexia. Hepatopulmonary syndrome is seen in approximately 25% of patients with chronic liver disease, and portal hypertension is commonly present in these patients. Hepatopulmonary syndrome is characterized by the triad of hypoxemia, intrapulmonary vascular dilatations, and chronic liver disease. So we present a case of a 25-year-old male who had a past medical history of depression and recently diagnosed cirrhosis, who presented to the emergency department with nausea and abdominal pain. He described a 4-year history of drinking between 5 and 20 alcoholic drinks on a daily basis. On presentation, his vital signs were stable on room air. His initial lab workup was significant for a white cell count of 31,000, hyponatremia to 118, hyperbilirubinemia with a total bilirubin of 10.9, and direct bilirubin of 6.5. He also had a transaminitis with AST and ALT levels between 2 and 3 times upper limit of normal. Based on this, he had a MELD sodium score of 31 and a MADRS score of 109. He was still taking 15 milligrams of prednisolone, which had been started on his previous admission when he was diagnosed with cirrhosis. His infectious and rheumatological workup for cirrhosis was negative, save for a positive COVID test on presentation, for which he was asymptomatic. His serum fibrosis score was indicative of severe liver fibrosis. He was noted to have ascites during his inpatient stay and underwent a paracentesis for this. His acidic fluid SAAG level was 1.6, which indicated portal hypertension. On day 8 of his hospitalization, he developed progressive dyspnea and hypoxemia, which was worse on standing, hence orthorexia and platypnea. He required 6 liters of supplemental oxygen while lying flat, however, needing 15 liters on standing. He was found to have ascites and bilateral pleural effusions, for which he underwent thoracocentesis and paracentesis. He also underwent aggressive diuresis, but remained hypoxemic despite these interventions. The differential diagnosis for his hypoxemia remained broad, including pulmonary edema, COVID pneumonia leading to ARDS, and intrapulmonary vascular dilatation secondary to hepatopulmonary syndrome. As further workup, he also underwent an arterial blood gas on 15 liters of supplemental oxygen, which showed a PaO2 of 155, meaning that he had an AA gradient of 363 millimeters of mercury. He also underwent a transthoracic echocardiogram, which showed a late, that is after 6 beats, interatrial shunt, confirming the diagnosis of hepatopulmonary syndrome. So the takeaway points from our case are that platypnea and orthorexia in chronic liver disease should prompt workup for hepatopulmonary syndrome. The severity of hepatopulmonary syndrome is defined based on PaO2 at rest on room air, and treatment for severe to very severe disease includes long-term oxygen therapy and liver transplantation, which is curative for hepatopulmonary syndrome also. Therefore, our patient was transferred to a liver center for further transplant workup.